Hi, Jackie. Hope you're doing well.
Hi there, good to talk to you all.
Could you please tell us what's the situation like in the US? Why aren't yet this kind of agreement as developed as in Europe, and what would make them more attractive to US payers?
Sure, well, one of the major difficulties in the US is that these kinds of agreements really need a unique patient record system. And, in the US, we have a very fragmented record systems because of the multiple health plans and systems and sites of care that are providing treatment. So this really kind of presents an issue, but it's not the only reason why these agreements haven't really gained any uptake in the US until now. They also involve tracking health measures and outcomes in specific patient groups, and the cost of complexity of that kind of tracking can offset the benefits. They're really data intensive, and tracking systems that are in place have been established to manage costs and budgets. So not always to measure medical or patient outcomes. For payers, it's been much simpler to push for simple price cuts, the simple rebate basis. And for pharma companies, it's also simpler because big and across-the-board price cuts have been avoided due to market fragmentation, multiple public and private payers, and insufficiently organized purchasers. But the whole marketplace is changing. And we now have a fast-growing payer segment that's contained within the health system and organized customer base. So hospitals and health systems are getting bigger. They're putting distance between their doctors and pharma companies, and it's making it harder for pharma companies to get quick acceptance of newly approved medicines and putting pressure on profits. Even today, 42% of doctors that practice are now salaried employees of health systems, whereas 10 years ago it was more like a 24% number. So getting a drug on formulary at a big health system can mean potentially millions of dollars in sales from thousands of doctors' prescriptions. Health systems are growing more powerful as they bulk up by buying hospitals, doctors' practices, urgent care centers, different providers and sites of care. And they're shifting reimbursement from how much care is given to how effective it is. So they're really incentivized on delivering the triple aim, which Yannick spoke about, I believe. Essentially, we're talking about value. So as an example, in COPD, Medicare will cut reimbursement if COPD treatment doesn't stop enough patients from returning to the hospitals. The Wall Street Journal, even earlier this year in May, put out an article that was talking about the new push tying costs of drugs to how well they'll work. And according to a recent survey, 1 out of 2 hospital systems declare they've switched to a value-based model, and they're seeing a positive return on investment.
Well, thank you very much, Jackie, for these insights.